My name is Jacqueline Thies, and I am a neurooptometrist practicing in Richmond, Virginia. I'm going to be talking with you guys today about fixational eye movements, a biomarker for neurologic and ophthalmologic disorders. You can get my slideshow to move. And my disclosures are listed here. My slides are not advancing though. Give me 1 second here. They were advancing literally a moment ago. All right, we're gonna do it this way. Okay, so what we're gonna talk about today is we are going to review the pathoanatomy of fixational eye movements, including the different subtypes of them. So microsaccades, tremor, and drift, and how they overlap with the macrosaccades that we're used to seeing. And I call them macro because they're big enough for us to see. Microsaccades are so small we can't see them. We're going to describe the vague visual symptoms that patients may have when their fixational eye movements are over or under responsive, and their implications in neurologic as well as ophthalmologic disease based on current research states. And then we're going to discuss the utility of fixational eye movements in diagnosis and treatment of neurologic and ophthalmologic disorders like Alzheimer's, Parkinson's, MS, TBI, AMD, and amblyopia. And if anyone can keep their mics on mute, there's some background going on right now that sounds like someone's in their car. Okay, here we go. So before we can understand, and I want to deep dive into how the eyes move, I always like to ask people, have you ever thought about why the eyes even need to move? And the main reason that eyes need to move is because of the retina. So we know that if our photoreceptors were evenly distributed in the retina, we really wouldn't need eye movements at all. We would only need head movements. But because the human anatomy has a central area in the fovea that's high density of cones, which is what enables us to have high spatial resolution and the ability to see 20/20, we need eye movements so that we can point our fovea at what we're looking at. And we know that when the visual image or the light that we're focusing from the lens onto the retina, if it's not perfectly on the fovea and it's parafoveal or into the macula, that our vision starts to decline. And we can see this clinically with our patients who have macular degeneration, because you've seen those patients where they've had terrible geographic atrophy and they have some, again, if you can mute your phones, that would be great, guys. So we know that patients who have geographic atrophy and have a little bit of the foveal tissue left, that they can do really well and see 20/20. And then you have other patients where overall their retina looks pretty good, but they have a small lesion in the dead center of the fovea and they have really bad visual acuity. And so because of the photoreceptors, we have to move our eyes all the time. And so we have different types of eye movements to do this. So in order to precisely put our fovea on the object of interest, we have to be able to do vergences. Vergences are disconjugate eye movements. So disconjugate means that the eyes are moving in opposite directions of each other. And so obviously we use this to track objects as they move towards and away from us. We also have smooth pursuits, which are conjugate eye movements that allow us to track a small moving target while our head is not moving. So the target's moving, but we're not moving. We have saccades that allow us to bring the image of interest onto the fovea rapidly. And usually we use this to move our eyes from object A to object B. And then we have the vestibular ocular reflex, which allows our vision to be stable while our head is moving. And there's two types of vestibular ocular reflex. We have the translational one, when we're rotating our head side to side. That's our
Sorry, I was muting somebody else, but you got caught in it. Jackie, could you just do me a favor and unmute yourself?
I can unmute myself. How long back was I muted?
About 30 seconds.
What was I talking about?
Who
knows?
Somebody tell me what she was talking about, please.
Vestibular ocular reflex.
Okay, so the vestibular ocular reflex. We have two types of vestibular ocular reflex. We have the rotational and translational. So if I am looking at an object and my head is moving side to side, that is our rotational vestibular ocular reflex. If we do this for long enough, eventually our VOR will transition into our optokinetic reflex, which is used for more prolonged head movement and gaze stabilization. But if our head's not moving side to side but our body is moving translationally, for instance, when we're walking or we're in a car, then our translational vestibular ocular reflex kicks in. And so all of these eye movements are required, and they're very large eye movements that most of us are used to measuring in our clinics in order to allow us to see precisely and accurately and with speed. But what about fixation? So let's pretend our head's not moving and our eyes are not moving, technically. That is what we consider fixation. And we spend about 80% of our visual experience fixating on things. Even right now, if you're looking at this slideshow, you are fixating on it. And it used to be thought that fixation was this passive state that occurred in between our active eye movements. So meaning Fixation was just kind of this thing that happens when we're not making a smooth pursuit or not making a saccade. And what research has shown is that actually fixation is an active state. And there are different types of eye movements that are being employed during fixation that we will call fixational eye movements or FEMs. And what they do is they hold the image of a stationary object on the fovea when the head isn't moving, but they allow the retina to move a little bit so that we can maintain precise vision. So why that's important? It's important because if our eyes aren't moving enough, we will actually get fading of our vision. And so we've seen this a lot in our clinic, right? The troxler fading effect. Our patient is doing a visual, it's always the Humphrey visual field. And all of a sudden the patient freaks out, everything went blank, I can't see anything. And it's because they were fixating so hard on the target that everything in the periphery just essentially faded away. And you can actually, if you look at the center of the small circle in this slide here, and if you look at it and really look at the dead center of that circle, if you don't blink and don't move your eyes over time, the peripheral circle will actually disappear in your peripheral vision. And that's the troxler fading effect. It's actually neural adaptation that's happening. And neural adaptation happens for all of our senses. It happens for smell, and it happens for sound, and it happens for vision. So the example I like to tell patients, because sometimes it's hard for them to understand this effect, is imagine smell. Smell is the easiest one to understand. If someone walks into a room and they're wearing like an awful body spray, initially it's just almost putrid. But over time, as you're hanging out with them, eventually that neural adaptation process will get used to that smell and you don't smell it either at all or as much. So you can adapt to whatever high stimulus change occurs over time if that stimulus isn't constantly changing. So when it comes to fixation, that means that if our eyes aren't moving enough and our fixational eye movements aren't moving enough, that our patients will actually have visual loss or visual fading due to neural adaptation. On the other end, if the eyes move too much, then the patient will actually get blurred vision or unstable vision or symptoms of oscillopsia. So very much fixational eye movements have this Goldilocks effect where they have to be moving, but not too fast and not too slow. They can't be too big or too small. They almost always have to be perfect for us to have the precise and hyperacuity that we have. And aside from just fixating on things, there's a lot of research coming around of what else is the point of fixational eye movements. And so far, things that they found FEMs to be responsible for include enhanced spatial vision, the ability to synchronize sensory and motor activity together. They're needed for modulating neural responses in the cortex, and they are heavily noted to contribute to the acquisition of visual information, which makes sense, right? I'm looking at something and I'm acquiring the visual information, and fixational eye movements are essential in processing visual information. So if we don't have fixational eye movements, it's hard to acquire, or our fixational eye movements are awry, it's hard to acquire visual information and process what we're seeing. And what about visual performance? So this is actually from a study that I did with a couple of other researchers. And what we looked at was, well, what if we just look at the difference between fixational eye movement in normal healthy controls and elite D1 level baseball players? And so what you can see here is that the control is down below, and you can see that there's, so it's, I know these graphs are a little hard to interpret, so I'll go over them a little bit. So this is over time. So we just kind of did a video recording of their fixation. So they're looking at a small target over time and seeing how the eye moves. Now red is horizontal. So in my head, whenever I read these, I take the horizontal and I orient it perpendicular so I can imagine the eye is moving side to side. So you can see here that normally the eye is going to move side to side. And then the blue is vertical. So not only is the eye moving side to side, but it's also moving a little bit vertically. So really the eye is moving in this oblique fashion. When we can compare that to those of the baseball players, what we found is that there was a pretty stark difference in the fixational eye movements, notably in the velocity and in the amplitude. So you can see here that the movements in general are much smaller in baseball players, and they were faster. And where that becomes clinically important was one of our wonderful researchers kind of mapped this out based off of what we found in our numbers and what it would be like in real life. So we imagined, okay, so let's pretend someone's looking at a baseball that is in the pitcher's hand at the mound, and the baseball player, right, at the pitching mound, and the baseball player is at home plate. So they're about that far away. Based off of that gaze angle, what does the fixational eye movement look like? And so what you can see plotted here is in red, if a normal control subject is looking at the baseball or at the pitcher, their eye movements have an error rate about the diameter of the baseball. So they're not, even though they're looking at the baseball, inherently their fixational eye movements are inaccurate enough that they're not exactly on the baseball. But when you look at the fixational eye movements of the baseball player, you can see that they have a much tighter pattern of fixation. And so their error rate we found was about the size of the seams of the baseball from that distance away from the mound. And where that becomes interesting for me is it makes you wonder, chicken or the egg? And I think all of us that work in rehab have always thought of this. Are baseball players at the elite level, are they elite because they innately have better fixational eye movements than all of us, which has allowed them to progress in the game because they almost have a one-up advantage on everyone else because they're better able to fixate? Or is fixation trainable? And I think that's a really interesting question that came from our posters here is, can we train fixation? And that's something that we're all going to have to look at and see, because that would be fascinating to look at both from a disease state, but also a sports visual performance perspective. So why have we not talked about fixational eye movements before? And, I haven't found a lot of lectures on FEMS. This is the first time I've ever lectured on FEMS. So I'm really excited about it because it's been a big passion project of mine for the last year. And it's because there's been a huge revival of interest in it. So let's look back at, it initially started being big in the literature in the 1950s. And that was the first time that they measured it. And there was kind of a big debate within the literature from the 1950s to the 1970s. And then the research just kind of stopped. And the main reason for that is because they just were not able to collect accurate data. And there was a ton of disagreements in the interpretation of the available data because they just didn't have the technology to be able to observe these eye movements. And then in the 1990s, we had this explosion of eye tracking technology. And all of a sudden, we're now able to use non-invasive eye movement techniques to be able to detect fixational eye movements. And so there's this huge fast-paced interest in FEMS right now. And it's one of not only the newest, but fastest moving fields in vision and oculomotor neuroscience. So it's really exciting and it's exploding. And I think we're only just going to start hearing about it, and it's just going to incrementally increase. So why are fixation eye motions hard to measure? Well, first of all, they're small. And I'm talking really small. So some of the components of fixational eye movements are the size of a couple of photoreceptors. And to think about the size of a photoreceptor in real life, photoreceptors is about less than 2 microns in diameter, and a hair follicle is about 70 microns in diameter. So that's how small a cone is. And if the eye movement is about the size of 2 cones, it's going to be hard to see. And oftentimes, I've been told, because I ask a lot about eye tracking technology, a lot of people have told me, well, the problem with fixational eye movements is that a lot of the movement patterns itself get lost in the noise of the machine. As a clinician, I didn't know what that meant. So as a clinician, what is noise of the machine? The noise of the machine essentially is, the machine itself is not perfect. So how can you differentiate if the movement is coming from the eye or the error of the machine? And if the machine is not sensitive enough, it's going to get lost, or you're going to get erroneous errors. So one of the things that I've kind of learned over the years is that in order to accurately assess the dynamic properties of eye movements, studies have shown that you need to have an eye tracker that is double the speed of the eye movement you're looking for. So not only are fixational eye movements small, but they're fast. So if we're looking at microsaccades, a saccade on average about 150 to 200 hertz in speed. That means that we need an eye tracker that is at least 300 to 400 hertz in speed to accurately measure the dynamics of it. And really, until recently, we haven't had the technology on the market to be able to detect accurately these eye movements. And I think we all know, working clinically, how important it is to be accurate and reliable with our eye tracker metrics. Nothing's more frustrating than having like an objective measurement like eye tracker data, and then you as a clinician are like, I know it's objective, but this was just not reliable. That's not how I saw the eyes move. They're not consistent with what I'm seeing in clinic. And so as a clinician, we have to be very judgmental of the data that we're getting to make sure that the tracker itself is being sensitive to what we need it to be. But I'm excited because technology, as we all know, is just getting better and better. And so I think we're going to learn a lot more about fixational eye movements as technology continues to improve. So one of the things that you'll see here, I kind of created this table out of a hodgepodge of different textbooks. And what you're going to notice a couple of things of is there's some blank boxes. So we don't know everything yet about fixational eye movements. And of what we know, every textbook is telling you something different. And a lot of that has to do with the type of tracker that was used to detect that movement. So tremor is a type of fixational eye movement, and it is the smallest. And on average, it's about 8.5 seconds of arc, but there's a range of how big it can be. Same with frequency. They'll say on average it's 90, but maybe 50 to 100. And we know that tremor is disconjugate. Whereas drift is a little bit bigger, than microsaccades are the biggest of our fixational eye movements. But to give people an idea of how big these are and how do we differentiate them from macrosaccades that we're used to already diagnosing in clinic, a macrosaccade by definition right now is any saccade that is bigger than 2 degrees in amplitude, and anything that is 2 or smaller is considered a microsaccade. And so obviously the bigger the movement, the faster they're going to be. So macrosaccades are going to vary in their velocity depending on how big they are. So let's get into the nitty gritty a little bit about these different fixational eye movements. So a microsaccade right now, because it's the biggest of the fixational eye movements, is going to be the most commonly studied eye movement right now in technology and research. And so a microsaccade is an involuntary saccade that is a jerk-like fixational eye movement that occurs on average for normal people about 3 to 4 times a second. And what it does is it intentionally produces retinal slippage and help prevent the troxler fading effect. Well, it's not technically troxler, but it helps prevent that neural adaptation and visual fading effect that can occur if our fovea is not getting inundated with the visual information in a moving fashion. So we know that the microsaccade is usually biased towards where we're looking. So it's going to move the image of locus off of the fovea and then direct it back onto it. And it's going to move the focus. So keep in mind, when we're talking about moving it, we're only moving across a couple dozen to a couple hundred photoreceptors. We're not moving like way off far into the macula. We're still within that foveal region. Now, what's critical about microsaccades versus macrosaccades is that while technically, I think a lot of us like to say that saccades are involuntary and objective, we all know that the bigger the saccade when we're testing patients in clinic, the more voluntary they are. I can definitely, if I'm doing a pretty gross saccade test where I'm putting my fingers out at about 45 degrees from primary gaze, A patient can decide how long they want to fixate on. Like, I would like them to go fast, but you always have the patient for whatever motivational factor. Maybe they want to hold their latency longer. And sometimes for patients with motivational bias or attentional bias, you can't always differentiate if their increased latency is due to attention or mood, or they are on purpose trying to slow down their saccade. Whereas with a microsaccade, they are under subcortical control. So if I'm just having someone look at a target, they cannot control the latency or the dynamic properties of their microsaccades. There are studies that have shown that the smaller the target you're looking at, the more you can change your microsaccade. What we mean by that is if I'm looking at my finger versus looking at threading a needle, my microsaccades may change in their behavioral patterns. So you can change your microsaccades, but from an attention perspective and a voluntary perspective, the patient can't really, if they're really trying to fixate, so they have to look at where you're looking, asking them to look at. But if I'm having them look at threading a needle and they're looking at it, they can't control the dynamic properties of their microsaccades. So microsaccades are going to be a much better involuntary and objective measurement than a macrosaccade would be if you're looking at getting it out of attention realm. Tremor, on the other hand, is, as we mentioned before, the smallest eye movement. So microsaccades, we like to think both eyes are moving at the same time. It's a conjugate movement, but tremor is actually disconjugate. And so the eyes kind of move independent of each other. It is the smallest of the eye movement. It is thought that it improves spatial resolution and may underlie hyperacuity, but there's a big debate in the literature if tremor even exists or if it's just a passive state. And I think, again, it's fun to read these literature battles, if you will, of what people think about this. But a lot of vision scientists are trying to figure out more about what tremor is. So tremor right now is a very minutia in the literature because people are still trying to measure it because it's so small. So how small is it? It's about the amplitude of a tremor movement is about the diameter of a foveal cone. So it's less than 2 microns, right? It's pretty small and it's pretty fast. Drift, on the other hand, is a little bit bigger. It's not as big as a microsaccade, but drift is going to occur simultaneously with tremor. And so what happens is the eye is kind of drifting towards and away the target of the fovea. It's a slower motion than a microsaccade, and it's what happens in between microsaccades. So you're making essentially a saccade off the fovea and a drift back, saccade off the fovea, drift back, or some patients are going to be making saccades on and off the fovea. But drift is what's happening between the saccades, and they can be disconjugate or conjugate. They can be independent between the two eyes. So when you're doing these eye movements, you might notice that one eye does one thing and another eye does another. So let's go to, because most of the research right now on fixational eye movements is done on microsaccades, let's go into saccades. So what we know about the neuropathophysiology of saccades, I kind of mapped here. It's complicated, right? So we know from a basic standpoint that we're going to have visual information coming from the eye, from the optic nerve to the LGN to the visual cortex. And then the visual cortex is going to send that information to the middle temporal area, which will then feed it to the frontal eye fields. The frontal eye fields will then coordinate with this supplementary eye fields, as well as the dorsolateral pontine complex. I might have mispronounced that, DLPC, and then the parietal eye fields. And then they're all going to kind of feed back on the superior colliculus. So one of the things that's complicated, obviously we know number one is making an eye movement to the left and the right, different pathophysiologies, making an eye movement up and down, different pathophysiologies, particularly in the brainstem. Making an eye movement up is going to require 4 muscles to move, whereas moving down is only going to require 2, and moving side to side is only going to require 2 as well. So different eye movements require different forces and inertia. And we also know that in addition, not only for saccades do we have to have an excitatory impulse, so we need to make the neurons, the burst neurons in the brainstem excited and move the eyes. We also need to have an inhibitory response on the saccade so that we're not constantly making saccades. So you have to have this balance of inhibitory and excitatory circuits on the superior colliculus. So the inhibitory pathway on saccades, which is important for later in the lecture, which is why I'm mentioning it, goes through the caudate nucleus, the substantia nigra, the basal nuclei, essentially. They're going to be controlling our inhibitory effects of saccades so that we're not constantly making saccades all the time. So from a microsaccadic standpoint, I highlighted in yellow here some of the parts that we know are also involved in microsaccades. So we know that the microsaccadic pathophysiology overlaps a lot of saccades. But microsaccades occur during fixation, and you actually have to inhibit a saccade to do a microsaccade. So we know that they're similar, but they're essentially different at the same time. So there's overlapping pathophysiology between them, but they're not the same thing. So this is the hypothesis of the pathophysiology of fixational eye movements, and there's a little asterisk here. So the current theory is that omnipause neurons in the nucleus of the PPRF are constantly firing to have an inhibitory influence on saccades. And then when the omnipause neurons stop firing, the saccades will then get an excitatory impulse to generate. The asterisk is there because there has yet to be a study that has shown that if we neutralize those omnipause neurons, that all of a sudden a person can't fixate. But that's kind of the current hypothesis so far. So essentially, the way that it's thought of is that the tonic activity of these omnipause neurons prevent us from making saccades. And then we essentially stop that inhibitory signal, and that allows us to make saccades. Once the superior colliculus gets the signal to make a saccade, they're going to make a saccade based off of its retinotopic map. So just like the occipital cortex, we know that the superior colliculus also has a retinotopic map of the world. So if you're fixating on something and another object appears within your visual field, your occipital lobe and superior colliculus are going to kind of map where that is relative to where you're looking to help you decide and coordinate where you're going to move your eyes from point A to point B. Where exactly your gaze is going to move, how accurate it is based upon your cerebellum. So when the cerebellum is impacted, we know that our fixational eye movements might be too big or too small. We see that in Parkinson's a lot with saccades. And then it's really important for accuracy. And then we also know that how many we're making, how often we're making them comes from cortical control. And so that's going to be your cerebral cortex, because your cerebral cortex is going to be the main generator of how much inhibitory and excitatory influence is going to be placed on the superior colliculus. So kind of complicated, but I wanted to highlight it because it'll be important when we go over some of the neurologic and ophthalmologic disorders later. But essentially the big thing to take home from this is when we look at microsaccades versus macrosaccades, it's not just a size difference. It's thought that perhaps there's this continuum of ocular motor control of when we do a microsaccade versus a macrosaccade. But I always kind of like to say right now, it's kind of like they're same, but different. And so they're not the same thing. It's not just like, oh, these are small eye movements. They are neurologically a different thing. And so here's kind of something cool. So this is the retina. Obviously, we all know that, but this is 1 degree kind of field of the fovea of the retina. And what you can see here is the eye moving. So this is a fixational eye movement in a normal person. And what you can see is it's mapping out over time here in real time. And so it's moving, as we can see, it kind of jitters a little bit up, a little bit to the side, a little bit obliquely. For those of you that are fascinated, I love this video just because you get to see the blood cells moving in the vessel. So it's kind of cool. And so that's kind of a normal fixation. A person with this type of fixational eye movement doesn't have a problem. They see 20/20. They don't say that their vision moves around them. And if they didn't have this eye movement, they wouldn't be able to see so well. So that's kind of what a fixational eye movement looks like. This, however, is a patient who has an abnormal fixational eye movement. So what you can see here, first and foremost, is it's much bigger, right? Much bigger than the last slide that we saw. So this is actually a fixational eye movement of a patient who complained of the world jittering, and she had a lot of just chronic fatigue. But when you looked at her in clinic on your clinical exam, even on your macrosaccade exam, she looked fine. She didn't have nystagmus objectively. Even if you looked at her under a slit lamp, you're not going to see a nystagmus. But when you look at her from a microfixational standpoint, she has a subclinical nystagmus. And what you can see here is that horizontal, we call these square wave jerks. So a square wave jerk means that you made a microsaccade away from the target, and then you made a microsaccade, and then there was a small pause, and then you made a microsaccade back to the focus. So you're going away and back. And what you'll see here, which is abnormal, is that the magnitude that this person is going away and back is not the same. So they're going away and then they come back. Here you can see that they go away in one direction and then they come back in a much larger amplitude. So that's an abnormal square wave jerk. For a normal square wave jerk, they should be the same. And this is kind of a plot of the movement over time, but you can also look at these plots from a polar plot perspective. So you're looking essentially at, well, how big, if I'm fixating on this target here, how close am I to actually fixating on this target? And you can see that this patient is pretty far away from fixation. So that kind of transitions us then clinically into talking about how fixational eye movements can act as a biomarker for neurologic and ophthalmologic disease. And knowing the group that I'm talking to here, I don't think I'm going to be falling on deaf ears of knowing that we know that the ocular motor system is a wonderful biomarker for neurologic function. And fixational eye movements are kind of starting to enter that game right now as a biomarker because we have only recently been able to detect them accurately. But we know not only do neurological and ophthalmologic disorders have abnormal ocular motor functions and convergence and smooth pursuits and saccades, but we're also starting to find out that very specific distinctive fixational eye movement patterns are emerging in different types of neurologic diseases. And where that's becoming important is because it may help to develop differential diagnoses and differentiate in certain types of neurologic disorders, maybe what kind of diagnosis the patient has. We also know that a lot of us can detect ocular motor dysfunction in people objectively in our clinical chair, but they probably were having abnormalities before them that were just subclinical and we couldn't see them until the disease continued to progress. So the theory, right, with fixational eye movements is if you're looking at a smaller eye movement or a microscopic eye movement, or you can see smaller things moving with better technology, you're going to detect the disease sooner. If we can detect it sooner, we can then maybe use it as a biomarker to track if your treatment option, whether it's a drug or surgery or therapy, is working, or it can help indicate, hey, this person might have this condition, you should initiate treatment. So we might be able to start treating patients sooner. So fixational eye movements right now are super exciting for me if you look in the literature on neurologic space and neurodegenerative disease in particular. But before we can figure out what is abnormal, the hard part I think we're gonna have to figure out is what is normal. And again, we're only just starting to understand this information because we're only starting to see it. So again, I mentioned this before, but what is a normal square wave jerk? Square wave jerks aren't necessarily abnormal. I know when clinically we hear square wave jerks, we're thinking about nystagmus in general that we can see in our chair, and those square wave jerks are abnormal. But a square wave jerk in fixational eye movements is normal because that's how they work. But essentially what you'll see here, right? So in a normal person, the magnitude of going away and coming back are the same. And you know that the magnitude is opposite directions, meaning I don't make a saccade here and then make another one in the same direction. The saccade goes away and comes back. And there's a pause in between. And the pause by definition of normal should be about 200 to 400 milliseconds. And you can see that they differ, right? So these are 6 different people, by the way. 3 people that are older and 3 people that are younger. You can see that obviously our fixational eye movements change over time. We're getting a little bit longer duration of our short intervals. We're getting more microsaccades in general. So we're going to have to define at what age does that happen. We're going to have to figure out and to collect more data to figure out, you know, when should we be concerned if they're having too many saccades or not enough? And that's something that will come with time. But what about the abnormal? So what I'm going to go over now is we're going to go over some of the disease states that we know have abnormal fixational eye movements and kind of the role that they play. So let's start out with Huntington's disease. So Huntington's disease is a disease where you get an accumulation of Huntington protein that leads to striatal or cortical atrophy. Now, the Huntington protein, essentially what it does is it causes degeneration of GABAergic neurons. But in particular, the first neurons that it's going to impact are those in the basal nuclei. So a lot of the neurons in the other part of the brain have the capability to degrade this protein. So they have some kind of proteins that can, or enzymes that can degrade this protein to protect them a little bit. But the basal nuclei neurons don't have those that ability. And so the basal nuclei is vulnerable in Huntington's disease to be the first area where people are going to have degeneration. And then over time, as they get more and more of this protein, eventually some of the other GABAergic areas of the cortex are going to get involved. And that's what leads to that progressive frontostriatal network and sensory cortice atrophy. It's not necessarily a common disease, but it's not uncommon. So about 43,000 individuals in the US alone have Huntington's disease. And what we know as far as prognosis is that it happens, the onset of symptoms, and when I say onset of when we were able to diagnose the symptoms, and you'll see what I mean by that in a little bit, is about 30 to 50 years old. So people are getting this at a very young age. And once the motor symptoms appear, which is usually when we're diagnosing this disease, individuals usually have about 10 to 20 years left to live. So as far as Huntington disease go in the rare disease space, it is not a diagnosis that is not, you know, it's a heavy-hearted diagnosis because a lot of people don't live very long after they've been diagnosed with it. And so it's important that we can figure out a way to diagnose it sooner and intervene sooner and develop drugs to help prevent the degeneration if we can. When you look at the progression of fixational eye movements and eye movements in general in Huntington's disease, so if we look and think back about the pathophysiology of microsaccades, we know that the inhibition of saccades starts in the basal ganglia. And so if the basal ganglia is going to have damage to it, then we know that we're going to have issues with our fixational eye movements as well as our saccades in this the earliest kind of abnormalities. So if you actually look at some of the clinical diagnostics for Huntington's disease, the first thing that they look at is saccades. But the saccades, when you look at it from a neurological perspective, the way that they're literally measuring it is using fingers, right? So looking side to side, you see hypometric saccades. By the time somebody has already seen saccadic dysfunction clinically in your chair, they've already lost over 50% of the spiny neurons in the basal ganglia. So if we can detect fixational eye movement and fixational microsaccade dysfunction prior to that, we'll be able to diagnose hopefully Huntington's in this preclinical prodromal stage of Huntington's. Often in this stage, patients have symptoms, but the symptoms are cognitive, mental, psychiatric. So a lot of them are depressed, 30 to 50 years old, they're depressed. And then over time, they will eventually get the motor dysfunction in grades 2 and 3 and get a diagnosis of Huntington's. And so we're diagnosing Huntington's very late, even though their symptoms started way before. It's just the problem is their symptoms that they started with were just depression. And then, of course, we know that when patients die, the leading cause of death is going to be aspiration pneumonia, but the second cause of death is actually suicide in these patients, not only because their prognosis is so poor, but because the diagnosis in and of itself also causes depression. Another disease state that has some implications with fixational eye movements is Parkinson's. So Parkinson's also is a neurodegenerative disease, but unlike Huntington's, you get death of dopaminergic neurons in the substantia nigra. And this leads to a dopamine deficiency in the basal ganglia. So again, the basal ganglia implemented, so you can see some commonalities there. And what happens here, though, is unlike in Huntington's, you're going to get uncontrolled excitatory impulses and movement disorders, so the tremors that we're normally seeing in patients with Parkinson's. And some patients also have Lewy pathology, which means that in addition to the death of dopaminergic neurons, they also have an aggregation of abnormally folded proteins in cell bodies and neurons. So if you see Parkinson's with Lewy body, that's essentially what they mean by that. We all know that there's a whole host of ocular motor manifestations in Parkinson's. Clinically, in our chairs, we're usually seeing convergence insufficiency. It's always the double vision that is impacting reading, but we know that smooth pursuits and saccades are also impacted in reading, as well as difficulties with upgaze. But in relation to fixational eye movements, it's been well documented for a very long time that these patients have prolonged fixation. They have that kind of stare where they have trouble moving their eyes from one place to another, as well as ocular tremor. And what's been interesting in the literature is that fixational eye movements have been able to differentiate different subtypes of disease. So within Parkinson's, there's many subtypes. We have progressive supranuclear palsy and multiple system atrophy. And in the very early stages of Parkinson's, it can be difficult to differentiate the type of Parkinson's they may have. And of course, that makes an impact in prognosis and treatment, because different drugs now and in the future are going to be targeting very specific types of Parkinson's, and you have to be able to know what type of Parkinson's the patient has to even put them in the clinical trial or give them the appropriate treatment. And so you can see here, there's a graph on the right, and what you can see is the fixational eye movement of a control versus the fixational eye movements of someone with progressive supranuclear palsy versus that with Parkinson's and CBS and MSA, and they're all different patterns. So the more that we can look at pattern recognition and fixational eye movements, the hope would be that not only are we able to differentiate Parkinson's from PSP earlier on in the disease state before it really manifests, so we can treat it in a different way sooner, but we can able to intervene. So it's pretty exciting in Parkinson's when you're looking at differentiation and using eye movements for that. The other reason it's important is because when we think of Parkinson's, oftentimes we think about the gross motor problems and implications of Parkinson's, but we know that the majority of patients are usually going to have a lot of non-motor symptoms before their Parkinson's motor symptoms develop. And so oftentimes patients with Parkinson's have been misdiagnosed with something else for years before they finally get diagnosed with Parkinson's. And part of the reason for that also is because no two people with Parkinson's, similar to brain injury, no two patients are the same. And so I will say, from a neurological perspective, it's a hard disease to diagnose early on because they have very non-specific symptoms. So cognitive impairment, trouble with smell, I mean, that can happen with age, right? We have loss of smell. Psychiatric symptoms, mood disorders, depression, sleep disorders, autonomic dysfunction like urinary incontinence and constipation, all those things happen with age. So you can see how it can be hard to diagnose someone who might have Parkinson's with some of these non-motor symptoms. So where it can be really exciting from a fixational eye movement ocular motor perspective is, well, we know that ocular motor impairment can also be symptomatic of cognitive impairment, and they are correlated with each other. So if we can have somebody with cognitive impairment and we detect that they also have an eye movement impairment, maybe that can help direct the diagnosis of the neurological disorder sooner, and then we can intervene sooner. I see here there's a diagnosis of dementia, so let's look at dementia. So we know that the most common form of dementia is Alzheimer's disease, which is present in about 50 to 70% of cases. This, unlike Huntington's, is pretty prevalent. So about 6 million people over the age of 65 in the US have Alzheimer's dementia, and it is a complex, multifactorial, multi-causal condition that has an abnormal accumulation of beta amyloid plaques and tau protein neurofibrillate tangles. And essentially what happens is these abnormal proteins, the plaques and the tangles, they disrupt cellular communication and axonal transport. And so essentially they're just neurotoxic. So we have kind of neural atrophy. We often know with Alzheimer's that oftentimes the symptoms of Alzheimer's disease start with just very mild cognitive impairment of memory loss, and usually noticed by the family members on average about 3 years before their diagnoses. And some people aren't even diagnosed with Alzheimer's or Parkinson's or Huntington, well, not so much Huntington's, but Alzheimer's and Parkinson's. Sometimes they're not even diagnosed with this until postmortem. And that means that they've been suffering with these symptoms for long periods of time. Pathophysiologically with Alzheimer's disease, we know that the pathology starts usually in the medial temporal lobe. So unlike Parkinson's, where we were worried about the basal ganglia and the inhibition of saccades, now we're looking at the medial temporal lobe, and that presents with impairments in episodic memory. So to remind those, if you don't remember like me how the pathophysiology works in saccades, the medial temporal lobe is really important in the very beginning stages of our eye movement. So it's how our visual cortex communicates to our frontal cortex the information, and it's a very large pathway in the not only excitatory but also inhibitory pathway of saccades. So there are different types of dementia. Alzheimer's is one. Another one is frontotemporal dementia. So this is a study that looked at eye movements in frontotemporal dementia, and ocular motor function is definitely impaired, but in general, they noticed fixation stability was a very impaired ocular motor movement, as well as anti-saccades. So anti-saccades and pro-saccades are different. Anti-saccades take more inhibition. And so to do an anti-saccade, what happens is if an object moves from point A to point B, if you're instructed to make an anti-saccade, it means you're instructed to look away from point B, not towards. Pro-saccade would be moving towards the object of interest. An anti-saccade is looking away from the object of interest. So if you're looking away from something you'd want to look at, that would be an inhibitory effect. So if the frontal lobe is important for inhibition. So if you're having trouble with your frontal lobe, you'll have trouble with inhibition, in which case you're going to have trouble with your anti-saccade. So that makes sense. And then in Alzheimer's and mild cognitive impairment, some studies have also shown that in general, the microsaccades are more oblique in direction in Alzheimer's disease and MCI than they are in normals. And so right now it's just really exciting looking at where eye movements could be in the potential of diagnostics, because I think right now, you can't treat something if you can't diagnose it. And there's a very hard time right now in differentiating who truly has Alzheimer's and who of mild cognitive impairment ends up getting a non-Alzheimer's type of dementia. And the treatments might be different. And there's a really hard trouble right now in the drug pipeline to treat, condition A versus condition B, if you have to wait for that disease to really manifest before you can differentiate which disease it is. So I think right now there's a big trouble right now in development of pharmaceuticals in this area, just because we can't diagnose it until it's end stage. And maybe pharmaceuticals aren't helpful in end stage. Maybe they're really helpful if you did them earlier, but we can't diagnose it then. So there's really just this conundrum going on right now, which hopefully eye movements are able to fix. So we'll only know as research develops more. This is the video we saw before, but I just want to remind you, this is what normal fixational eye movement looks like. So this is a patient, age match control, normal fixational eye movement. And you can see over here that, right, we have some microsaccades, but what I want you to look at is in the next slide, we have someone with mild cognitive impairment. And what you can see here for this patient, and it doesn't mean all patients, but so far for this one, that their amplitude and frequency of microsaccades is much higher and much more common. So again, we need to do way more studies to understand what is normal so we can differentiate what is abnormal and then figure out how we can differentiate one neurocognitive disease from another. But pretty cool, especially because this eye movement in an early stage is going to be asymptomatic. So the patient's still going to see 20/20. They're not going to notice any type of problem. And the final disease state neurologically that I want to go over is MS. Now, MS actually is one of the most researched conditions correlated to fixational eye movements. So we know that multiple sclerosis is a peak onset in females more than males about 20 to 40 years old. It's prevalent, about 1 million people in the US have it. And we know that the incidence is increasing globally. And it's a chronic autoimmune disease of the central nervous system that causes inflammation, demyelination, and axonal loss in both the brain, optic nerve, and spinal cord. And so it's this multifactorial problem. So what currently is thought of is that, like many other autoimmune neurodegenerative conditions, there's a genetic predisposition for a patient, and there is an environmental trigger, like the Epstein-Barr is one, cigarette smoking, and some type of environmental trigger that causes inflammation that leads in these individuals to this autoimmune trigger, and the disease manifests. So it's one of the most frequent causes of neurologic disability in patients. And a lot of us see these patients in our office because more often than not, patients with multiple sclerosis are going to present with optic neuritis. And so we see them a lot in our clinic due to optic neuritis. But also sometimes they're in our clinic. I've diagnosed multiple patients with multiple sclerosis because they came in with internuclear ophthalmoplegia or a cranial nerve 6 palsy or different abnormal eye movements due to white matter lesions. Depending on where the lesion is, obviously it's going to be what oculomotor dysfunction they're going to present with. When we look at the type of ocular motor problems in MS, there's a lot of good statistics of, 40% are going to have problems with saccades and smooth pursuits, 70% are going to have nystagmus of different types. And they say fixational instability, but there's really no current diagnosis of how many patients with MS have fixational instability. We just know it's common in them, but not how common. So again, all things that are going to come with time. And the hard part with MS is the ocular motor problem in MS is going to be inherent on where the lesion is in the brain. And it can be anywhere. I think, when I used to teach students, MS is one of those diseases where it can surprise you. So you'll have a patient and you see them and you think this is definitely just a cranial nerve 6 palsy. It's probably ischemic. You send for the MRI and boom, it comes back and you're like, oh, just kidding. They actually have MS. That's happened to me more often than not where it'll surprise you. And it's because, we like to think that pathognomically an INO is going to be MS, but we know that INOs can occur in patients with brainstem strokes as well. And actually it's more common in brainstem stroke in an older population than younger. But we also know that if the lesion's anywhere else, they might not have an INO. They might have any other type of ocular motor impairment. So what about FEMS in MS? So this is some images of fixational eye movements. Both of these patients, by the way, asymptomatic, subclinical. But what you can see in patient A here is a downbeat nystagmus. So you can see here, the eye is drifting up, downbeats, drifting up, downbeats, drifting up, downbeats. And one of the things you'll notice is the downbeat is not the same magnitude all the time. And so you can see that they have a subclinical nystagmus. This patient, on the other hand, so that's a vertical motion. This one is a horizontal motion. And so what you can see here is that this patient has a square wave jerk nystagmus. And the square waves, as I mentioned here, they don't have the same amplitude, and that's abnormal. So the magnitude of the square wave jerk is not a normal magnitude, and also the duration and number. So they have varying amplitudes, and they have different refractory periods, although it's around 200 milliseconds, which technically can be within norms. And again, this just goes to kind of show the differences. I just liked this graph mostly to give you guys an idea of what a square wave jerk looks like when it's normal. So one of the things in general, I asked one of the lead researchers in fixational eye movements in MS, how would you best describe FEMS in MS? And the way she kind of characterized it is they're more likely to have fixational eye movements that have a larger vertical motion than the average control. And they're more likely to have pendular nystagmus. And in 75% of the patients that they were looking at, they had a combination, one or the other or both. So they have square wave jerks that are abnormal, more often in the vertical meridian, or this pendular nystagmus, which is, you can see this pendular nystagmus here. And again, in all of these groups right up here, a lot of these are subclinical. So if we can diagnose this sooner, we can diagnose MS sooner, start them on treatment sooner than when they've already presented to our clinic with a lot of the bigger findings that we're normally seeing in our chair. And we know that there are different types, as I mentioned here, of nystagmus. That's what this graph kind of shows is, and that's not surprising that all patients have different types of up versus down versus leftward drift, and they're all a little bit different, but we know in general, the vertical is going to be more impacted in patients with MS. And what's interesting is that the fixational eye movements have been linked to the disability scores in MS. So we know that they have more microsaccades, larger vertical amplitudes, and that microsaccades can actually provide an objective measure of MS disability level and disease progression. So as the microsaccades get worse, the disease gets worse. And that's important because right now, there's not necessarily a very objective marker sometimes for disease progression in MS, because sometimes the white matter lesions on the MRI don't match the disease progression. So there's some limitations with MRI. And so a lot of studies right now are looking not only at fixational eye movements, but retinal tissue as well, and looking at thinning in the retinal tissue in addition to fixational eye movements and disability score in MS. And not only is this important just from a regular disease state, but we also have to think as optometrists from a visual quality of life. So we know that patients are going to have larger square wave jerks, which means they're going to have more complaints of visual focusing. And it's going to be frustrating because these patients are going to be in your clinic and they're going to say, I have a hard time focusing, and people are going to be increasing ads and trying to refract them. And it doesn't matter how well you refract these patients, because at the end of the day, the problem is fixational stability. So in general, we know that they're going to have a lower visual quality of life. And the problem is that at the same time, they're losing motor function. And so whenever a patient, whether it's MS or Parkinson's, is losing motor function, the way that we compensate for loss of motor function, if I can't move my head or I can't move my body to be able to interact in my space, I'm going to move my eyes more. But if my eyes are inaccurate, I can't compensate for my loss of motor function with my eye movements. And so it's going to severely impact their quality of life. And the problem with this is we know that fixation is going to impact a lot of their very specific near acuity. Near acuity for us is most important in devices. And a lot of these devices that are coming out to help patients with their ADLs, we need to make sure from a low vision standpoint that they're big enough. And it makes sense, right? Their fixational eye movements aren't working, which means most likely the visual signal on the retina is going to be parafoveal. So these patients might be 20/30, 20/40, 20/50. And even though they might have a normal looking retina, they may benefit from a low vision evaluation and adaptability kind of evaluation, just orientation and mobility, to make sure that they're getting the font size that they need to be able to interact and do the things that they enjoy. The other thing that I say, I work with a lot of patients who've had MS, a lot of them that are in end stage MS that are in a wheelchair. We have to make sure that we do a really good job of single vision modalities. I love single vision modalities because their eye movements can really jerk around where they are. It's hard for them to be in a precise position of a progressive lens. But the other thing is that you have to recognize that some of the devices that are attached to their wheelchairs may be at a different working distance than we're accustomed to. And so you need to make sure that you're really measuring the working distance for patients. I know that's not related to fixational eye movements, but this is my soapbox on working with patients here, is making sure that we provide them with the optical clarity for the distance that they're at, and that you might have to reduce their ad so that they can be at a farther working distance. And you have to make sure that you're increasing their font size. The other thing that we know in neurodegenerative diseases, in addition to having trouble with fixational eye movements, they usually will have reduced contrast visual acuity because of thinning in the retinal layers, in which case that's important because we need to make sure that we also enhance contrast for these patients because we might not be able to optically make it big enough depending on what their eye movements are doing. What about TBI? So this is a newest study. It actually literally just came out in 2021, but they essentially looked at, well, what about the fixational eye movements in patients with acute TBI, concussion, so MTBI. And what they found was there was a difference clinically significant in the fixational eye movements in those with acute MTBI who had a longer recovery rate. And so they were able to differentiate those from concussed patients from healthy controls, and then which ones were more likely to have a longer recovery. So fixation, and it's again a very small n, needs to be confirmed with more data, but really promising in being able to differentiate who might have a longer disease course. And from a management perspective, in my opinion, that's important because we want to be able to tell our patients, hey, I know you had a concussion, I expect you to have a longer recovery because your ocular motor and function is impaired. And that helps them from a clinical management, because I think everyone, Google's concussion, they think they're going to be better in 7 to 10 days. And when they're, going on week 2 and 3, they start to get really anxious. And if we can avoid that anxiety and just get them know it's more common, and get them linked into a neuro-optometrist or a developmental optometrist sooner, so that they can get rehab sooner, I think that would be amazing. And if we can get these devices in hands of other providers so that they can at least make the diagnosis of eye movement disorders even better, right? So we can kind of intervene sooner. So let's jump to, I promised ophthalmologic disease. I'm a big fan of neurologic disorders, but what about ophthalmologic disease? So this was an interesting study in 2019 that was looking at fixational eye movement waveforms in patients with amblyopia. And what they found was really interesting. So what you're going to see here, just to describe the graph. So these are the fixational eye movement patterns when the eyes, so right eye is red and pink, and the blue and kind of teal is the left eye. And so what they found was both eyes viewing, that you have a certain level of binocular viewing. And then with the majority of patients, when they had essentially the dominant eye view, the fixational eye movement pattern got more accurate. And when they had just the amblyopic eye view, that the amblyopic eye had a more abnormal fixational eye movement. So what they're finding is that not only do they have reduced visual acuity, but they have reduced fixational eye movement patterns as well. And what's important about this is the binocular pattern is worse than the dominant eye viewing at all. So I know we often think, oh, if somebody has amblyopia, they're just using their dominant eye. They're not really using that they're not really using the amblyopic eye at all. But what these fixational eye motion studies have shown is actually they're using that eye. And not only are they using that eye, but binocularly their vision is worse because they're using that eye. So if we can improve the amblyopic eye, it just goes to even say more that we need to improve the vision in the amblyopic eye because it will improve their binocular vision, not just from a suppression standpoint, but from an acuity standpoint and fixational eye movement standpoint as well. And this is another study looking a different way of looking at the graph. And you can see here that if they're not looking with their dominant eye, or they're looking with their non-amblyopic eye, they have a very tight fixational movement pattern versus if they allow binocular vision, in which case then the movement pattern is impacted by the amblyopic eye, which has very abnormal fixational eye movements. When they looked at treatments, this is a different study that looked at treatment of patients with amblyopia. What they found is those that had fixational instability and fixational eye movement dysfunction, those were the patients that tended to be at a higher risk of regressing with part-time occlusion therapy and require a prolonged duration of treatment. So I think from a management standpoint, being able to do fixational eye movement detection would be fascinating in my amblyopic population to know, like, hey, maybe we're going to do a slower taper of that patching therapy. Maybe I'm going to patch you longer because you're at a higher risk of regression, or maybe I'm going to follow up with you sooner because you're at a higher risk of regression. We know that they're less likely to have good stereo acuity, and that makes sense based on the previous slide. And we know that amblyopic patients with nystagmus but no fixational instability actually had improvement in visual acuity and stereo acuity. So what that means is that even though a patient may not have nystagmus, if they have fixational eye movement dysfunction, they're going to have worse visual acuity because of fixational eye movements. And then in maculopathy, there have been some studies as well looking at the role of fixational eye movements. And so essentially in adults who have macular disease, their fixational eye movement patterns are more erratic than those that don't. And that makes sense because you're using it. It's a feed forward and feed backward neurologic continuum, right? So if you can't see it, it's going to be hard for you to direct your fixational eye movements if you don't actually have a phobia. So it might be another way to objectively detect the functional ability of a patient who has a maculopathy or an ARMD disease. And then I only have an hour, so I couldn't go over everything, but these are some of the other conditions that if you were to look up fixational eye movements that current clinical trials are looking at. So one of the big things that I like to say with fixational eye movements is they're super exciting. No one is talking about them enough, and they're the future. So I'm really excited that I had this opportunity to talk with you all, and I'm going to jump to the chat and see if there's any questions for me. Okay, so great question here. So Elisa, I think I said that right, asked if clinically, are we just seeing only macrosaccades? And yes, when we direct voluntary saccades, so we're doing them in office, whether we're using an eye tracker right now, there's nothing that I'm aware of clinically on the market that can detect in our clinics right now an eye tracker. Obviously, this will change with time. Fixational eye movements and microsaccades. It might be able to map the fixation pattern, but not the dynamics of fixational eye movement because you have to have a tracker fast enough to do it. So clinically, especially if you're not using an eye tracker, you're only seeing macrosaccades. You're not detecting fixational eye movement at all. And so, yeah, she said she's here without instrumentation or technology. So she absolutely is looking at macrosaccades. Doug Major asked, why is the younger eye tracking have more jitter and the older baseline is a more smooth line? Great question. We have no idea. So that's where I was saying one of the problems right now is if you look at some of the studies on fixational eye movements, the N is very small. And so we have to really do more research in normals to figure out what normal is and what impacts it. So things that we know that was listed on the other slide that may have been an issue here, we know that attention is a problem. ADHD can be a problem. Schizophrenia, depression, mood disorders, sleep disorders can all have impact on fixational eye movements. There was an interesting study that I found at the American Academy of Optometry poster presentation where a clinician, not myself, I found it there, had presented what was the impact of caffeine on fixational eye movements, and essentially they found no impact. So couldn't be a caffeine or, which was interesting. So we don't know yet, but it was a great question, and we don't know if it's another factor that they had prior to taking that test. Another question was, in neurodegenerative Alzheimer's disease, can you explain its ocular manifestations, alterations in ocular motility and visual perception? I could talk about that for an entire hour, to be candid with you. So we might have to put a pin in that. But essentially what we know with Alzheimer's disease from a fixational eye movement standpoint is that they are more likely to have oblique fixational eye movements. Some of them can have, and some of them can also have convergence problems. A lot of it depends on where exactly they're having the dementia within their brain, because one of the problems with cognitive attention, as cognitive attention goes down, is cognitive attention is going to drive our eye movements. So you're going to have differences with macrosaccades as well when patients have enough dementia, because you have to remember where you're going. So you're going to have some abnormalities. If you want me to move from point A to point B and then back to point A, I have to remember where point A is, or remember what the task is. So the level of dementia is definitely going to impact your eye movements. We also know that eye movement, as they get more irregular, can cause more disorientation and spatial orientation problems. So it's all over the place right now, to be candid with you. But I will create another lecture on Alzheimer's disease and let you know. But great question. Dr. Major says, it seems that microsaccades tend to deviate more in the horizontal direction. Is there a reason why, or some neuro disease associated with vertical? Great question. So I think I answered that a little bit later. So in general, we have more horizontal movement than vertical movement in normals. And so there are certain conditions where we're finding that the microsaccades have a wider amplitude on the vertical. So MS was one. Progressive supranuclear palsy was another one, where we find that there's more of an impairment in the microsaccadic direction vertically than horizontally. And that's one of the ways that people can differentiate PSP from Parkinson's, is the impact of eye movement on the vertical direction compared to the horizontal. So it depends on the disease state. And that is because, as I mentioned in the very beginning, making an eye movement vertically is a different neuropathological pathway than horizontally, in which case it's going to matter where you're getting a lesion within the brain, which eye movement is going to be impacted and how it's impacted. Okay, are there any studies related to nutritional intervention and improving fixational eye movements? To my current awareness, no. But I think the main reason for that is because right now we're still trying to differentiate what is normal versus abnormal. There are a lot of studies going on right now looking at using eye movements as an objective biomarker when they do drug interventions. So this is fixation, their pattern. We implemented a drug and we're seeing if fixation gets better, worse, or stays the same. So sometimes fixational eye movements right now are being used in pharmaceuticals as a biomarker for objectively for neurologic dysfunction. But I think one of the problems is when you're looking at nutritional intervention, you have to figure out why the fixational eye movements are abnormal. Is it neuroinflammatory? Is it neurodegenerative? And if it's neurodegenerative, what is causing the neurodegeneration? Because for any nutritional intervention, just like any pharmaceutical, you really have to hone down biochemically to what is exactly the problem. And then the nutraceutical, which in my opinion is a type of pharma drug, is going to be going in on that pathway. So I'm sure in the future, there are going to be a ton of studies using fixational eye movements and nutrition, and it'll go back and forth of if we can tell that the neurologic function is getting better with this nutritional intervention, then we would assume that the FEMs are going to get more accurate as well if they're a biomarker for neurologic function. Another question, can computed eye tracking analysis of the King-Devic test detect persons with objective mild cognitive impairment early when clear clinical dementia symptoms are lacking? From my awareness, the King-Devic test, the spacing of the numbers on the King-Devic test are going to be larger than 2 degrees in magnitude, in which case you're going to be looking at macrosaccades and not microsaccades. So the question itself, though, is just, can computed eye tracking analysis detect persons with objective mild cognitive impairment earlier? I think this is, and I think it's a wonderful question. I can't definitely say yes. I can't also say no. And I think the problem right now, and that's where the future of technology and kind of integrating AI and technology and clinical intuition is really going to change the scene, is because what we really need to understand is pattern detection. So, okay, let's say somebody has objective abnormalities on the King-Devic test. What about those objective abnormalities is in someone who is, as you mentioned, lacking clear clinical symptoms of the disorder they end up having? How do we differentiate that abnormality is developmental? How do we differentiate it that it's maybe because they had a motor vehicle accident or a TBI? And I think part of that is going to be in comparing the symptoms and using AI algorithms to understand pattern differentiation. But for AI to be able to help us do that, we need more data. So I think there's a future in that, but I just don't think that we're there yet. And yes, so Dr. Addy added a wonderful link to an article on shortening of saccades as a possible easy to use biomarker to detect risk of Alzheimer's. And I think I agree. So we're looking at using saccades in the oculomotor system to detect Alzheimer's. One of the things I always give a caveat to with clinicians, and this is something that a lot of people are putting publications out there on saccades. And the first thing I do when I look at a publication is I look at what type of eye tracker they used, because if they didn't use an eye tracker that is sensitive enough to really accurately measure amplitude, direction, and velocity, meaning that the hertz of that eye tracker better be double the speed of that eye movement, some of the data might not be accurate. And the most important thing for me when I'm reading these studies is how accurate and reliable is the data that they're publishing. Because one of the things that I've found sometimes is we have these really big grand gestures and conclusions from some things that are interpreted in a very abnormal way. For example, there was a study that has been quoted over and over and over again in Parkinson's, saying that patients with Parkinson's and Alzheimer's are more likely to have primary open-angle glaucoma. And people have been quoting that forever. And I finally went back and dug up this study, and the N was of like 12 people in each group. So it wasn't a big group of studies that I think you could make a statistically significant conclusion from. And then the other problem is that they found optic nerve head thinning and they found retinal nerve fiber layer problems, but they didn't find any increase in intraocular pressure in those patients. And so they're saying it's primary open angle glaucoma, but maybe it's actually neurodegenerative retinal nerve fiber layer changes, and that's not glaucoma at all. And so we have to be careful when we're interpreting data that we make sure that everything in the methodology is sound clinical judgment, and that what they're using is going to appropriately and reliably give us the data that we're looking for. So what eye tracking hardware do you recommend for accurately measuring microsaccades? So right now, if you look at the comparison of eye tracking hardware, the things that are clinically on the market, most often that we're going to be able to find are going to be pupil trackers, scleral trackers, pupil trackers, corneal reflection trackers are the most common. There's a debate in the literature whether those are accurate enough. So coming down the pipeline are going to be retinal trackers. And one of the things that we all know clinically is that the pupil is a dynamic structure. It's a big structure. So if we can start tracking smaller structures more accurately, then technically we should be able to see microsaccades a little bit better. But as of right now, there's actually, even for macrosaccades, there's a debate in the literature if pupil trackers are actually able to accurately measure macrosaccades. So if you're looking for that paper, Hooge, H-O-O-G-E, he is a researcher in Europe, and he has some excellent publications, as well as Nystrom, N-Y-S-T-R-O-M, excellent publications on comparison of different types of eye trackers and what would make it accurate versus not accurate. So I would guide you to look through the literature and kind of look through the hardware there. And hardware and software matter too. So the software can also be important in that detection. Addie went to bed, but it's probably 2 or 3 a.m. in the morning. So I'm glad she finally fell asleep. All right, another great question. And man, Doug Major and I need to just have a good conversation. So he asked, since the vestibular system is hardwired to the extraocular motor system and has a million action potentials always on and bounce between the two eyes, could that be the cause for the jitter? What is the vestibular component of fixational eye movements, in my opinion? All right, so we're going to go back to, I don't know if it'll let me. I don't think it'll let me. Hold on, give me 1 second, because I want to go back to this slide. Boop. Okay, this was a question I had, and I had this for a different reason. It had nothing to do with microsaccades. It had to do with macrosaccades and VOMs. So for whoever asked this question, one of the things that I had an issue with, as we all know, if you work in the TBI space, is that a lot of people are doing vestibular therapy for people with saccadic dysfunction. And one of the things that bothers me is we know that as saccades get larger, we actually use our neck muscles more to help support our head while our eyes are moving than we would use our vestibular system. So the question I had asked, which is what I was looking through pathophysiologically, was at what point is the vestibular system even involved in saccades? Because technically the vestibular system is made for head movement, not eye movement. And so we know that there's a cervical ocular motor connection and a vestibular ocular motor connection. And the vestibular nucleus is only involved in saccades when you are gaze holding. So what that means is if I make an eye movement rapidly from A to B, and again, we don't know yet, to be candid with you, the vestibular mapping with microsaccades, that has not been shown. But from a macrosaccade perspective, we know that the vestibular nucleus is only involved when someone has made a saccade in an eccentric gaze and held it there. So for instance, when you're doing ocular motility and they look outside, whenever you see the eye drift and we get that end gaze nystagmus, it's actually because the vestibular nuclei is not able to engage it and hold the eye movement in that eccentric position. And that's why it's slipping, is because the vestibular system is not able to hold that gaze. But if you are not actually holding the eye for a long period of time in the eccentric gaze and you're just quickly moving your eyes from A to B, technically the vestibular nuclei is not involved at all. So it's an interesting question. In my opinion, if the head's not moving, I think the cervical connection is more likely firing than the vestibular. Whether the vestibular is always on, I don't know, but I will say clinically, I have patients, for instance, with peripheral and central vestibular dysfunction, and some of them have trouble with saccades and some of them don't, and it depends on where they're looking. So I don't think they're related, to be candid with you, but there's no study to back that up. So I apologize. It's just kind of off the cuff. I think they're different, but great question. I do wonder, and this is kind of my own thought, is how much is the neck involved in fixational eye movements? Meaning if I have a neck problem, does it impact my eye problem? And the reason that I say that is that the neck, if you're moving your eyes from A to B quickly, and even just fixating, we know that our eyes are constantly moving. There's a lot of inertia in that movement. And you have to think about, when I even just move my eyes this way, I am rapidly moving my eyes against an elastic force within the eye because there's orbital fat and orbital tissue and muscles. And so in order for me to have that sheer force, physics would say that for every action, there's an opposite and equal reaction, which means in order for my head to not go with my eyes when I'm moving them, so in order for me to not have a head nystagmus, my neck has to flex. So we know that the larger the saccade, the more that our neck is going to flex. And that's why I've been really interested in the cervical oculomotor connection more than the vestibular when it comes to saccades and microsaccades. Dr. Gerlach, we should talk offline on software. I'm interested on your comment there. Oh, sorry, Addie, I kept you awake. It looks like that is, oh, one more question. So what speed of an eye tracker will be sensitive to fixational eye movements? So as of right now, I would say it would have to be about 400 Hertz because we think that fixational eye movements are about 150 to 200 Hertz. So you want to double that according to the Nystrom theory. So you want to double that. So you're looking for something that's, I would say 400 Hertz, I think you're going to be safe based off of that theory. And that's to be able to detect the properties of microsaccades. So it doesn't mean that you can't pick up fixation on a lower Hertz tracker, but if you want to actually be able to accurately detect the properties of fixation, you'll need a 400 Hertz to get an idea of research grade. So what the Hertz magnification, so what we're able to get in our clinic and what researchers are able to get into their labs, totally different. And so there are a lot of eye trackers out there that can go up to 1,000 Hertz, but they're research grade, they're not FDA approved, they can't be used in clinic. It's frustrating. It's very frustrating for me as a clinician because there's some eye trackers out there that are great and you can't put them in your clinic. But that'll change, right, with time. There is a lot of eccentric fixation circuits in the cerebellum. This is an area of great new research that's powerful as a great area of neuroplastic response. Agreed. And that makes sense that there's eccentric fixation circuits in the cerebellum because the cerebellum is going to be in charge of gaze accuracy and where you're going to point your gaze. So the cerebellum has to know where you're going eccentrically because it's going to be in charge of how accurate that saccade is in that direction. So that makes total sense to me. All right. Any other questions? Cool. Dr. Addy was happy. All right.
Going once, going twice, and you can use your reactions to tell us what you thought. Look, like me, I'm hand clapping now.
And if anyone has any questions or comments, like I said, this is my first time actually kind of putting my excitation for fixational eye movements out into the public into a presentation. So any feedback, good, bad, is very welcome. And you can email me anytime. So, all right.
Let me join